Thank you. So, my presentation will be related to ablative approach to thyroid nodules. I have nothing to disclose. There is not a conflict of interest. Before I start my presentation, I have to do a special thanks to Dr. Beck from South Korea, who guided me in my first steps on RFA. It's a teacher and encourager, and above all, a friend. Well, when we are treating thyroid nodules, the opinions of how we can manage it and how we can follow the thyroid nodules varies a lot sometimes. There is a controversy and constant changes in how we treat these nodules. My presentation will show a new trend in the treatment of thyroid nodules. When we're starting to use a new technology, such as mobile phone or a medical device, there is a curve of adoption. In terms of RFA, we are in this part, the early majority. I suppose not only in America and Brazil, but all across the West, except Italy, where this treatment option has been used for many years. In Brazil, we started to use this technology 4 years ago, and we have already overcome the chasm. That's when you begin to do a new procedures and no ways pay attention to it. It's a time gap when you do a new procedure and the people ignore the procedure. We move it into the early adopter phase 1 year ago, and when the technique started to spread, we are now in this part of RFA, the early majority. A significant portion of our colleagues accept this approach to treating thyroid nodules. That's why, as Dr. Toto already mentioned, recently many important thyroid societies got together to publish the new guideline for the use of RFA, and I'm very honored to be part of this outstanding team that wrote this guideline. Well, we know that up to now, surgery has been the best therapeutic option for treating benign symptomatic thyroid nodules. But surgery, of course, has relevant concerns, like the cost of surgery and the risk of temporary or permanent complications, especially related to recurrent laryngeal nerve and parathyroid glands. But the most important for patients is the effect on their quality of life, having to use hormone forever. So why minimally invasive treatments? We know that almost 150,000 thyroidectomies are performed every year in the United States, and 53,000 patients developed thyroidectomy cancers in 2020. This way, you can see the most thyroidectomies are with benign disease. Now, 20 years after the first publications, ultrasound ablative techniques are proved as a safe and effective treatment for thyroid nodules. Among these, RFA is one of the most widely used procedures in specialized centers. We know that more and more patients are concerned about their quality of life and the easy access of information. You know, Dr. Google is reached 1 million times a day. This information encourages patients to seek less aggressive treatments. Now, new technologies are available to safely ablate thyroid nodules without removal of the gland itself. This patient, you can see this picture of one of our first patients with autonomous thyroid nodule. That above, you can see the patient at the day of RFA, and below 6 months after RFA. It's important to know that the thyroid function of this patient normalized after 4 weeks after the treatment. want to show this recent published revision by this Korean group that advocates RFA. It's a reliable option for benign and autonomous thyroid nodules. The main indication, of course, is for symptomatic or cosmetic problems that the patient have related to the volume of the nodule, but also for treat autonomous thyroid nodules. It's a good option in selected cases. It's important, and I will explain later for you, that we have absolutely right that the nodule is benign. So we need at least 2 benign results on FNA, or a cytopathologic confirmation of benignity, plus an ultrasound features of these benign nodules. And one important thing, if necessary, you can repeat RFA as many times as necessary. Okay, RFA is easy to master, reproducible, effective, safe, and doesn't require sophisticated ultrasound equipment. It can be used as an alternative to surgery to manage solid, mixed, even solid cystic, functional or non-functional thyroid nodules. RFA is used more than laser, microwave, and HIFU because of its simplicity and reproducibility. And one important factor, in my opinion, of course, is the cost. RFA is cheaper than other procedures. The most important thing when we talk about these procedures is that ablation therapies must be carried out in specialized centers. And it's another important point. It requires ultrasound and anatomical expertise. This is the essential part, in my opinion. In performing RFA, you need a strong knowledge of ultrasound anatomy. It's the most important part of master RFA. So since 2050, minimally invasive thyroid nodules therapies has been discussed more often in all the world. RFA can also be done by surgeons, radiologists, and clinicians. You don't need any special training before RFA. I want to illustrate, I want to show my master class in Korea in 2018. In this class, we have surgeons, radiologists, ENTs, and endocrinologists, all training RFA. Well, in terms of safety, I will show my own experience over 300 nodules treated by RFA. Of course, the most important complaint patients is pain. Is doing because RFA, the basis of RFA is heat. The RFA causes coagulative necrosis, so it can up to 70 Celsius grades, and you literally melt the nodule. Ecchymosis is also very common. Skin allergy, cough, dysphagia, temporary hoarseness are all related. I have to say that I have one case of vocal fold palsy and 2 cases of Claude-Bernard-Horner syndrome. Of course, this case of the beginning of my learning curve, but now, as long time, we don't have any important complication. As you can see here, a patient, 1 day after RFA, and the same patient 34 days after the procedure. It's remarkable. We can see the remarkable difference in the volume of the neck. You can see here on the left, ecchymosis and multiple punctures in the skin. So why so many punctures? Because the patients have many nodules. We need to reach the the middle of the nodule in the correct position of the needle, we need to do many punctures. That's why in many patients we associate not only local anesthesia, but also light sedation. But it's important to say that patient is very happy with the results. Another important point is understanding that RFA is a treatment modality that the final results come at least a year after handling. As you can see in this paper from this Italian group, the nodule shrinks remarkably in the first 6 months and more slowly in the next 6 months. After this period, after 1 year, you should not expect a relevant reduction of the nodule. The size remains the same. But it's fascinating, as you can see on the left, even though the nodule the size of the nodule remains stable, some patients have the sensation that the nodule is still decreasing. That's especially for cosmetic results. It's interesting. It's another interesting point. Well, this is a very interesting case that I want to share with you. It's an experience that showed me that the difference between to treat a patient with RFA and to treat a patient with surgery. This patient had his ablation in June 2019. So this ultrasound is 1 year after the procedure. When he came first to me, I told him, you have a huge nodule. You need at least 2 sessions of RFA. We'll do the first session now. We'll wait 1 year, see the results, and then we'll do the second session. And he told me, okay, doc, let's do the second session. Let's do 2 sessions. I don't want underwent surgery. I want to keep my thyroid function. I want to do this two times this procedure. I prefer do 2 times RFA than surgery. Well, so the patient, when the patient came to me, the volume of the nodule was 73 cubic centimeters, and I performed the first session of RFA. And after 6 months, the volume was 41 cubic centimeters. And then after 1 year, the volume of the nodule was 35 cubic centimeters. Then I told him, okay, let's do the second session. And he told me, oh no, doc, I'm okay with my nodule. It doesn't bothers me anymore. I feel comfortable with the nodule. I don't want to do the second session for now. And I made a deal with the patient. Okay, we'll follow the nodule, and if he started to grow again, we'll do the second session. Well, since then and until now, the nodule is stable. Here, it's important we treat the patient nodule, the patient symptom, and not the nodule itself. Another important point is that when you use RFA, you cannot use the TRAD system to evaluate the nodule because the appearance of the nodule changes dramatically after the procedure. As you can see here, one nodule is not the same nodule, one nodule before the procedure and just after the procedure, when you can see this part treated and this part not treated yet. It's very different one from another, and it's not possible to use TRAD system. That's why you need to be absolutely sure that the nodule is benign. Well, here is another example, and when the nodule is not so big, the RFA results are much better. Here we have a 32 years old female. The volume of the nodule was 8 cubic centimeters, as you can see here, but the patient was thin, and the presence of the nodule bothered her a lot. So another interesting thing I want to show you is the vascularization of the nodule. This is the pre-RFA Doppler, and the same nodule 3 months after RFA. You can see the nodule dramatically decrease the vascularization after 3 months. Only in this dangerous triangle zone remains a little vascularization. That's it, because we need to be very cautious in this area, because it's close to recurrent laryngeal nerve, esophagus, and tracheae. We need to be very cautious in this area. So, in this case, the reduction of the nodule after 5 months was 80%. 80% in 5 months. And the patient was very happy. And the nodules still shrink. And another important thing, you need to think in terms of nodule. We need to think about the volume, not the size. It's an important factor when we think about ablative therapies. We need to think about the volume of the nodule, not the size of the nodule. This way, regarding RFA for benign nodules, it's for me now, it's one of the best choices for treat benign nodules. It's effective, it's safe, you don't need medication, there is no need for general anesthesia, you no need hospital stay, there is no scar, and it can be safely repeated if necessary. And of course, this meeting is a meeting about thyroid cancer, and I will talk about the RFA to treat malignancies. Here we can have, and as Dr. Tuttle already mentioned, we have another path between surveillance and surgery. As you can see here, we have a patient with micropapillary thyroid cancer that we treated by RFA. Here you can see the tumor, the needle inside the tumor, and the treated area. The treated area seems to be bigger than the tumor area, because when we treated malignancies, we treated differently. We approach malignancies differently from benign. When we treated malignancies, we need to reach an area beyond the tumor as a safety margin. So that's why after RFA, it seems that the nodule is bigger. In a recent paper, showed the results of 84 patients treated with micropapillary cancer by RFA. It's interesting to note that in the first months, the nodule size could demonstrate a growing. This occurs, as I told you, to the technique to treat micropapillary cancers, where the area treated is more significant than the size of the nodule. Then, after 6 months, the nodule started to shrink, and shrunk faster in the first 6 months, then slowly. And after about 1 year, the reduction rate is about 50%. But as you can see here, about 2 years, literally all the nodules vanish, which is very, very interesting. Another important paper, and this paper is very interesting, compares RFA for micropapillary thyroid cancer with surgeries, even lobectomy or total thyroidectomy. The efficacy of RFA is similar to surgery, but with the advantages of less adverse effects like hypoparathyroidism, vocal fold palsy, or other side effects. The conclusion of this paper is that for carefully selected patients, RFA has the same outcomes with lower level of complication and lower cost and a better quality life. Of course, we need more follow-up and additional studies to confirm these findings. Here, I will share with you one case of our group, a small papillary thyroid cancer in the border of the thyroid. And here you can see the early aspect of the nodule in the area beyond the thyroid after the ablation. You can see it's just a few days after the procedure, the area, as we showed previously, area is bigger than. And on this photo, the first month after RFA, the 3 months after ablation, where we can't see any more identifiable lesion, but of course, edema and fibrosis on the strap muscles. But 9 months after RFA, you can see a complete disappearance of the nodule. So it was very, very effective. Another application of RFA in our daily practice is in the treatment of parathyroid adenoma. You can see here on the yellow arrow, the parathyroid adenoma, and the same patient 6 months after the procedure in the green arrow, we cannot identify the adenoma anymore. Another important application of RFA in our daily practice is in the treatment of metastatic lymph nodes metastasis of papillary cancer in selected patients. Our master class in Brazil, and we invite you to attend one of our courses. I will show a recent case that we do 2 weeks ago. A patient, we treated this patient 2 weeks ago. This patient has a solitary recurrence of a papillary thyroid cancer, level 3 of the neck. She had 2 surgeries previously, and you can see the jugular vein, the carotid artery, and the metastasis. And here you can see the needle inside the metastasis. Here's a special needle with just active tip of 4 millimeters. So we can treat in very delicate way the metastasis. This is our group. Together we treated more than 600 patients. And to wrap up my presentation, I want to leave you with some take-home messages. RFA is changing the philosophy of how we treat benign nodules. We should not treat the patient. We should not treat the nodule. We should treat the patient. It's important to change how we see, how we deal with benign nodules. RFA is providing us with a new tool that we can use to treat thyroid nodules. We should master the technique. In my humble opinion, now RFA could be considered the first line therapy for symptomatic benign nodules, and a good, reasonable option for selected micropapillary thyroid cancers. Something that, Something that surprised me when I started to perform RFA was I suppose that the patient would search for a way to avoid surgery. No, it's not true. The main concern for the patient is about taking hormones for the rest of his life. And RFA can help prevent not only the surgery, but the need for medication forever. Thank you. Thank you for your attention.